right. Thank you so much for that introduction and for having me today. Like I said, my name is Sarah Iberg, and I am in internal medicine and pediatric trained, and currently spend about half of my time in the division of adolescent medicine. So today we are going to talk about gender affirming treatment in adolescents. First, I have no disclosures. Objectives that we are going to focus on today. So first, we're going to discuss the evaluation of adolescents for gender affirming treatment. So what does it look like when a patient is going to come into my clinic and have an evaluation? Next, we'll review gender affirming treatment options for adolescents, and we're going to compare a little bit of what that looks like as compared to adult treatment. And lastly, we're going to outline consent of minors, particularly as it pertains to gender affirming treatment. So I was going to say, let's just take a moment and acknowledge the elephant in the room, but I would say that it has been sufficiently acknowledged since we have been here. But I do want to take a moment and just talk briefly about legislation that is happening. And this will kind of compound on what was discussed yesterday. So this is the map, very similar to something that was shown yesterday, looking at the current legislation map for gender affirming bans on youth. This is from the Human Rights Campaign. Currently, there are 19 states that have enacted legislation that restricts or bans care for minors, and 8 other states that have policies or laws that are under consideration. The Human Rights Campaign estimates right now that about 30% of LGBTQ and transgender youth live in states that currently have a ban or legislation enacted. Here in Utah in particular, like we talked about yesterday, SB 16, which is the Transgender Medical Treatments and Procedures Amendment, was passed on January 28th of 2023. And this legislation, as we discussed, is pretty nuanced. There's a lot of detail and still a lot of unknown, but I get a lot of questions, particularly regarding, can we still treat adolescents? Who is still qualified? All that kind of stuff. And so I just wanted to go over a few takeaways that you can bring back to your clinic and help kind of give you an idea of who and what you can counsel patients about. So first is that there is no gender affirming surgeries for any patient who is under 28. The diagnosis needs to be documented before January 28th, 2023. And this is particularly referring to the gender dysphoria diagnosis, which is an F64 code. Commonly, these diagnoses are going to be coming from primary care visits, office visits. They also can come from therapy visits, but they need to be documented prior to January 28th. I've run into providers who have said, oh, okay, great, I'll get the diagnosis in. And unfortunately, if that diagnosis is coming after January 28th, it does not count. And then for patients who have a diagnosis that is prior to January 28th, but they have not started on any medications, they do need to undergo 6 months of treatment prior to the initiation of medications. Okay, so moving on from legislation, let's talk about an evaluation. First, I'm going to touch a little bit on just general gender development. So there's actually a lot that we don't know about gender development. We know that there's a lot of factors that go into the development of gender for children. We know that these include biological factors, which are going to classically be your kind of nature factors, but there's also a lot of socialization, more nurture factors, and we don't really know how much one influences more than the other. But what do we do know? So we know that by about age 3, children are able to identify differences in gender. So this is a little bit more basic of like, mommies tend to be girls and daddies tend to be boys. But then by the age of 5, children are going to have a much more stable reference to gender, and this includes stereotypes as well. So that girls wear dresses, they like pink, they wear makeup, and that boys, have shorter hair and they play rough and get dirty. But despite these known stereotypes, even in that young age, gender expression fluctuation can be normal. So we can see in children that they can fluctuate this gender expression of sometimes liking more boy things, sometimes liking more girl things. And this can be considered within the realm of normal and is not always pathologic. So when a patient comes into my clinic, I'm going to start with what we do in medicine for all new patients and take a really thorough history. First thing I'm going to do is talk about a thorough gender journey history, and things that I'm asking about. First is going to be the age of onset. So what age did they start exploring a different, gender? Is this someone who has been this way their whole life? They started presenting this gender, as toddlers, and they've been really steadfast in that presentation? Or is this someone who started exploring their gender a little bit later, maybe into their teenage years? I ask about how did they find out about gender diversity? Again, is this a patient who has known and been very steadfast their whole life, and this is just who they are? Or at some point along the line, did they meet somebody from the LGBTQ community? Did they meet someone who's transgender and suddenly was like, oh my gosh, I relate to that? I ask about social transition steps that they've taken. So have they found a different name that they want to go by? Are they using different pronouns? And I really ask about who in their life are they using this with? Is it just with their really close friends? Do their parents know? Most of the time, if they're in my clinic, their parents do know. Does the school know? Do extended family know? So I ask about, who in their life knows about their gender identity. Are they wearing different clothes, different hair, playing around with makeup, anything like that? And with these social transition steps, how does that make them feel? Does it make them feel more euphoric or maybe not? I ask about gender dysphoria symptoms that they may be having. So what do they find distressing about their body? Are they starting to go through puberty? Are they having bodily changes that they're really finding distressing? And what in particular is distressing for them? And then I ask about goals of transition. So a lot of my patients have done a lot of research and they've, found stuff on the internet, and they actually have a pretty good idea of medications that we offer and some general idea. And so I ask about their goals for transition because a lot of times they already know kind of what they're looking for. So after I've taken a really thorough gender journey history, then I'm going to take a thorough mental health history. So things that I'm asking about. So first is going to be any prior diagnoses. So we know in LGBTQ youth that we have high rates of associated anxiety and depression, but we also have high rates of anxiety and depression in youth in general. So has someone made a diagnosis, whether that's their primary care doctor or someone else? Do they have any diagnoses that are outside of that might impact their care, like ADHD, bipolar disorder, anything like that? I ask about hospitalizations. So have they ever been hospitalized for mental health, for suicide attempt, suicidal ideation, self-harm? When was their last hospitalization? How long ago was that? I ask about treatment. So are they on any medications? Is it a simple SSRI that is prescribed by, their primary care doctor or their pediatrician? Or are they seeing a psychiatrist that they have a little bit more complicated regimen? Have they seen a therapist? Are they currently seeing a therapist? Is that part of their treatment? I ask about that. And then with every, especially initial evaluation, but really every follow-up visit, asking about any red flag symptoms. So screening for suicidal ideation, self-harm, things like that. Are there any red flag symptoms that we need to address their safety right then and there? Okay, so after, we talk about their gender journey history, we talk about their mental health history, then I see if they are established with a mental health provider, and this is most commonly going to be with a therapist. We have long since required our patients to be with a mental health provider, at least for some, part of time, but now with the new Utah legislation, it's actually a requirement in order to be on and continue with gender affirming treatment that they have to have a mental health provider. So if I have a patient who doesn't have a therapist, we talk about resources on how to find one and get plugged in with one. So after we've taken a really thorough history, then we're able to make a diagnosis. So diagnosis that we're going to use is gender dysphoria. The DSM-5 defines gender dysphoria as a marked incongruence between one's experienced or expressed gender and the sex assigned at birth, duration lasting 6 months, and manifested by at least 2 of the following. And I'm not really going to belabor a lot of the diagnostic criteria points, but in general, just having distress from their current assigned gender and desire to have features of their identified gender. I do, though, want to bring attention to the second point, and that talks about a strong desire to rid one's primary and or secondary sex characteristics. And the DSM makes a caveat in it about young adults and a desire to prevent the development of anticipated secondary sex characteristics. And this is actually a really important caveat. So commonly in patients who are young and haven't started to go through puberty, they may actually not exhibit really any dysphoria symptoms. Prepubertal bodies tend to be pretty androgynous, and so they haven't started to see any changes that they find distressing. And so the DSM made a caveat that it can count this desire to prevent the development of secondary sex characteristics. So in the clinic, we'll talk about, well, what would it look like if you develop breasts? What would it look like if your testicles enlarged and your voice got deeper? And if there's sort of dysphoria around even the anticipated symptom, that will still qualify in the diagnosis. Okay, so now getting into treatment. And really, when I talk about treatment today, this is going to be a little bit more broad class of medications that we use and generally how they work, but I'm not really going to get into kind of nitty gritty in terms of specific dosing and monitoring, all that kind of stuff, but we will touch on how our medications we use them a little bit differently than in adults. So medications that we're going to talk about. So first, we'll cover puberty blockers. We'll talk about options for menstrual suppression, anti-androgen medications, and then finally, gender-affirming hormone therapy. So puberty blockers have been in the news quite a bit in the last 6 to 12 months, and have gotten a lot of attention. I think there's a lot of misconceptions about what puberty blockers do and what they don't do. So really, I just want to start with the basics of what are puberty blockers, how do they work, and when do we use them? So puberty blockers are gonadotropin-releasing hormone agonists. It comes under the generic name of Leuprolide, and then it's under brand names of Eligard and Lupron. And I just want to specify that when we use the term puberty blockers, we're more so referring to the specific use in children. So these medications are used for a lot of other things. They can be used for endometriosis, fibroids, prostate cancer. So this is not the only use of these medications, but when we use the term puberty blocker, we're more specifically referring to its use in children. So on the white half, or hopefully the right side, is what it looks like if we don't have any intervention, and basically puberty just kind of progresses without any medical intervention. And then on the yellow half, it's going to look like what happens if we use intervention and we start puberty blockers. So puberty is all going to start in the brain. Starts up at the hypothalamus. And the hypothalamus is what's responsible for actually releasing the gonadotropin releasing hormone. And it does that in a really specific way where it's going to release it in this pulsatile manner. So it's going to have release of hormones and then it's going to stop, and then have release of hormone and it's going to stop. And this gonadotropin releasing hormone is going to travel down in that really specific pattern to the pituitary gland. And it's going to bind to the receptors at the pituitary gland and send these messages also in that pulsatile messaging fashion. The pituitary gland is able then to interpret that really specific message and say, okay, let's release LH and FSH. So the LH and FSH is going to be released from the pituitary gland and travel down to the gonads. So this is going to be either ovaries or testicles, whichever a patient has, and signal to the gonads, hey, time to make hormone. So then the gonads are going to release their testosterone or estrogen, and thus puberty progresses. So then on the yellow side, what happens if we use medical intervention? So puberty blockers look exactly the same to your natural gonadotropin releasing hormone. And so we give the medication and it's going to bind to those same receptors in the pituitary gland. But instead of having that really specific pulsatile messaging, it's actually going to just bind there and send a pretty constant message. And what happens is initially the pituitary gland is going to say, oh, okay, time to release some LH and FSH. But over time, with that constant message, it's actually going to taper off and no longer release the LH and FSH. And so once the pituitary stops releasing LH and FSH, you don't get messaging that goes down to the gonads. And without that messaging, the gonads do not make testosterone or estrogen, and then puberty pauses. And if you were to stop this medication, the white half would eventually pick up and resume. So when do we use these medications? The first scenario I'll talk about is the little bit more classic version of puberty blocking and preventing puberty progression. I tell patients there's 5 stages of puberty. The first is going to be stage 1 at the top. And basically you haven't started puberty. This is a prepubertal body. Then you have stage 5 at the bottom. And this is pretty much puberty is done and you have an adult body. The first time we are going to even consider starting a puberty blocker is going to be in stage 2. And this is a really important takeaway that we do not start puberty blockers unless there's some sort of sign that puberty is actually started. Okay. There's kind of a range of when you can use puberty blockers. So you can start as early as 2, and depending on the indication, you can use them up to around stage 4 to 5. But if you're really looking for that nice little window of when is a really good time to start a puberty blocker for a patient, so they have demonstrated that they have started puberty, but we have not gotten to the point that they have a lot of changes that they find distressing, that kind of right in 2 to 3, Tanner staging is what we aim for. Sometimes we have patients that come in and we're able to do start puberty blockers at that point. Sometimes we don't, and that's okay too. Other than using puberty blockers to suppress puberty progression, the other time that we will commonly use the medication is our anti-androgen. And we'll talk a little bit more about that later in terms of the uses for that. So criteria to initiate. So this is going to come from the WPATH guidelines. First, an adolescent has demonstrated insistent, persistent, and consistent pattern of gender nonconformity or gender dysphoria. And this is what I'm going to gather in my history when I'm taking that really thorough gender journey history. Next, symptoms of gender dysphoria emerged or worsened with the onset of puberty. And this goes back to that point that we have patients, if they have not started puberty, may not have dysphoria symptoms, but they will start to emerge and worsen as their body starts to change. Other mental health comorbidities or other social and medical problems have been addressed. So this is why I'm taking a really thorough mental health history, and I'm making sure that we're not really in a crisis, that mental health is in an okay and stable enough place to initiate medication. We think about social barriers that might be a factor in terms of transportation, are families able to come to visits, things like that. It's a lot less common for our adolescent patients to have other medical problems or comorbidities that make management more complicated like it is in adults, but we do see if there's history of other, medical problems that may factor into their treatment. And then finally, consent from the patient and parent and or guardian, and we'll talk about that a little bit more later. So moving on from puberty blockers to menstrual suppression. So we are able to use medications to stop menses and periods in adolescents if they find them distressing. These patients are typically going to be patients that in general find their estrogen production to be distressing. So most commonly, we're going to use medications of progestins. There is a couple of different options that are acceptable to use. So norethindrone acetate and medroxyprogesterone are both oral options that you can use in adolescents. IUDs and Nexplanons are acceptable to use in adolescents, although they are procedures. And so that can be much more invasive. And I will say, if I have a patient who's been managed by their primary care doctor and comes to me and they are on a combined oral contraceptive that does contain estrogen and they're doing well on it, they don't have side effects, they're tolerating it, they like the results that they're getting, you don't necessarily have to change that. But generally in our patients, we use progestin only options to prevent adding in more exogenous estrogen. So in adolescents in particular, far and away the most common of those options that we're going to use is going to be agestin or norethindrone acetate. We use this one in particular for a couple of different reasons. First, it is a progestin only and doesn't contain any exogenous estrogen. Secondly, oral is typically going to be the preferred route of administration for adolescents and kind of the best tolerated. Like I said, IUDs and Nexplanons are perfectly okay options, but many of our patients are fearful of undergoing a procedure. Many of them have never had a pelvic exam, so that would be quite invasive and very dysphoric for them. And so using an oral option usually is their preferred route. And then the nice thing about norethindrone is that it does leave room for some dose adjustment. So if we start at the starting dose, we're not getting all of the results that we want, we're still having maybe a little breakthrough bleeding, we do have room for a little bit of dose adjustment to increase that. Okay, moving on to anti-androgen medications. So we use very similar anti-androgen medications. These I think of for patients who tend to have some sort of distress or dysphoria from their levels of testosterone. This can include, non-binary or gender fluid patients, and it really can include patients who have a desire to eventually feminize or maybe not. So spironolactone, just like in adults, we will use spironolactone as one of our main anti-androgen medications. This tends to be a little bit more of our choice particularly if patients are unsure, don't think they want to add a feminizing hormone later. We will commonly use spironolactone. And it's believed to work in kind of two different ways. So first, it will block the testosterone receptors. And so testosterone has actual less effect because it can't bind and send downward messages. And then it also is believed to work by decreasing the conversion of testosterone precursors into testosterone. And so that's where you get a little bit more of the actual lowering of testosterone levels. Next, bicalutamide. So we do, and it is okay to use bicalutamide in adolescents. I will say this is certainly my second line option. and we don't use it nearly as much. This is a testosterone receptor antagonist as well, but doesn't really have any effect in lowering testosterone levels, just more so the effects. And so I do have patients who are on it and who do like it, but I would say this is certainly more of my second line option. And then finasteride. So finasteride is a medication that is used to block sort of the conversion from testosterone to its more potent form of DHT. We do not use this medication as monotherapy, but we will use it and add it on to other regimens if we don't feel like we're getting sufficient anti-androgen. Or if we have patients who are on testosterone and getting kind of androgen side effects like hair loss. So you can use this medication in adolescents. All right, so now finally moving on to gender affirming hormones. So we do follow WPATH guidelines. And the criteria to initiate is going to be really similar to that we kind of talked about earlier with puberty blockers, in terms of having this insistent, persistent, consistent pattern of gender nonconformity or dysphoria, talking about symptoms that are worsening with puberty. We really talk a lot about the mental health comorbidities, having consent. But the big difference between the gender affirming hormones is going to be your letter of support from a mental health provider. Now, why do we get a letter of support? So first, a mental health provider can assess the symptoms of gender dysphoria, and most importantly, provide a space for an adolescent to explore their gender. Like we talked about in the beginning, not all gender diversity and not all gender expression is necessarily pathologic and necessarily needs intervention. And so having a therapist that's able to create that space and time for these adolescents to explore their gender, figure out what their gender means to them, all that kind of stuff is really important. Next, a mental health provider is able to assess the patient's understanding of treatment. I spend a lot of time, usually over multiple visits, counseling and discussing with patients what the risks and what the benefits and all that kind of stuff look like for hormone therapy. But a mental health provider is able to kind of assess, what do they understand about that? Are they understanding some of the permanent aspects of hormone therapy? And does everyone on board feel like they have a good understanding of what they're getting into? A mental health provider is able to speak to the mental health comorbidities. So I think a lot of our therapists are only focusing on the gender dysphoria, but rather they're kind of exploring how the other anxiety and depression affect a patient's life. And so they're also able to be kind of a second eyes and ears to say, yes, mental health is in a relatively stable place. Me in particular, when I think of mental health stability before starting hormones, things I think about is, when was the last hospitalization? Was it in the last 3 months? Are we making really active medication changes and titrating up or coming off or switching medications? And then, is there any active suicidal ideation or self-harm? And those are kind of the big things I in particular think about that show mental health stability. But a therapist is able to explore that as well and speak to our patients being in stable places. And I really just overall feel like a letter of support is sort of this letter that states, yeah, we have done the work, we have talked about this, we understand what the implications are, and everyone feels like this is a good decision moving forward. Okay, so let's start with feminization. So very broadly, feminization is the concept of taking medications in order to achieve more feminine features. These are commonly going to be breast development, softening of the skin or hair, having a more feminine face, and then redistribution of fat from the shoulders down to the hips and waist. Just like in adults, when we think about feminizing regimens, we need both a feminizing hormone and an anti-androgen. And this is really because in order for the feminizing hormone to work, you need to bring down the testosterone levels. If we do not do that, the doses that we need of the feminizing hormone typically need to be so high that it now becomes potentially unsafe. And so we use the anti-androgen to lower the testosterone levels and then to allow for the feminizing hormone to work. So I would say the two most common medications that we're going to use in our clinic is spironolactone and puberty blockers. And like I said, we do use some bicalutamide, but these are going to be the majority of what we use. So how do we decide which medication is right for each patient? And we spend a decent amount of time talking through some of this. So first, unfortunately, is going to be cost, especially when we think about our anti-androgen options. Spironolactone is pretty darn cheap. It's commonly on your kind of $4 generic list and pretty affordable for many families. Puberty blockers, on the other hand, are quite expensive. Insurance coverage really varies on them depending on their plan. And sometimes that makes it affordable, sometimes it doesn't. Just to give you an idea and a reference, if we have a family who wants to just pay straight cash out of pocket for a puberty blocker, it's going to be about $1,200 a shot, which is going to be twice a year. And so this can be a big barrier for a lot of people to use puberty blockers. And so we talk really realistically about cost. Adherence-wise, spironolactone is a twice-a-day medication. And for a lot of adolescents, that's like really hard to remember. They can barely take like their once-a-day medications. So twice a day can be difficult. Versus with a puberty blocker, our patients will come into the clinic, they get their shot once every 6 months, and then they don't have to think about a medication at all. And so adherence is really high. Other things that we think about is just, we ask a preferred route. Do you prefer oral or an injection? I have patients who are terrified of needles and they hate shots. And even though we talk about how each of them works and all that stuff, they're like, no, give me the oral option. I don't want a shot. And some are okay with taking a shot because they know they're not going to remember. In terms of spironolactone, we think about and we counsel blood pressure, electrolytes. I would say for many of my patients, it's quite well tolerated. We don't have issues with blood pressure or orthostasis, but it is something that we talk about. And then for puberty blockers, they are kind of painful. Rarely you can have injection site reactions, but that's pretty uncommon. So you really talk through kind of all of these options to figure out which one is best for each patient. So then when we add a feminizing hormone, it's going to be estradiol. Comes in 3 forms: your transdermal, your oral, and your injectable. Again, we think a lot about the same things and talk through a lot of these to figure out which option is best for each patient. Cost-wise, the patches tend to be a little bit more expensive than the oral and the injection. Adherence-wise, a patch is pretty good. They put the patch on, they change it out twice a week. They don't have to remember, an everyday medication. And so the transdermal option is quite good for a lot of adolescents. Oral is still very common for us, but we do eventually titrate up to a twice-a-day regimen. And then injection, for our patients, we pretty much exclusively are going to start on transdermal and oral, and it's not really going to be until later in their therapy that we're even talking about the injection option. Although it certainly is an option, very uncommon, at least in my practice, for us to start with that. Other things that we consider and think about, so with the patches, particularly with patients who may have history of like eczema or other skin problems, we think about the skin irritation and rashes that can happen with the transdermal, adhesive issues. So if it's not sticking and it's falling off, that's pretty hard. With the oral route, are they okay swallowing pills, swallowing tablets? And there's certainly in our patients, it's still this perceived effectiveness. I would say that they've done their research and they come in and they're like, I read and I know that the oral is better than the patch. And then we just, it absorbs better. And part of it is counseling that that's not necessarily true, that we can get really good levels and really good effects with any of the routes that we choose. It's just a matter of talking about which one is best for them. And kind of across the board, regardless of what option we start with, I would say one of the biggest differences when we're treating adolescents than when you think about adults is our starting doses are a lot lower, right? So for reference, I would say an average starting adult dose for estradiol, particularly oral, is going to be somewhere around 2 milligrams. Our starting dose pretty universally is 0.5 milligram once a day. So we're starting at much lower doses, and we feel like for adolescents, their bodies are growing, their bodies are changing, and their receptors are pretty sensitive to these hormones. And so you just don't commonly need as high doses. We see them really frequently, every 3 months. Sometimes that goes past even the first year, and we take a while to space out those visits. We're checking labs all the time, and I would say our titration as we increase doses tends to be a little bit slower. At most, we maybe will do 1 milligram of increase, but commonly we also will do 0.5 milligram steps. And so that's really where a lot of this deviates from adult care, is that we start low and we go very slow. I tell patients commonly that their puberty doesn't happen in 3 months. It doesn't happen in 6 months. It takes years. And so I really try and kind of give this expectation of we're mimicking puberty with this. And so it's going to take a while. Okay, moving on to masculinization. So same concept of taking medications in order to have more masculine features. These are commonly going to be symptoms of, lower voice, developing facial and body hair, having more defined jawline, and then redistribution of fat from your hips and your shoulder, or from your hips and your waist up to your shoulders. There's not a 2 medication regimen or anything like that. We just use testosterone. And our 2 options for routes are going to be topical and injectables. Again, talking through all of kind of what route is best for each patient. Cost-wise, topical actually tends to be more expensive than the injectable. We usually use a compounding pharmacy that helps make it more concentrated. So our adolescents are not slathering a ton of cream or gel on their bodies to get the appropriate dose. But cost is going to be a little bit more expensive than just a vial of testosterone. Adherence-wise, topical is a little bit more challenging. It is a daily medication. Typically want to put it on after a shower onto clean, dry skin. And so making sure they feel like they can, do you shower every day? And so making sure that is a reasonable route for them versus injections that are just going to be once a week. Other consideration, again, sensitive skin reaction, things like that to topical options. And then pain or giving yourself an injection. So this is a real thing that, we talk through with patients. Fortunately, a lot of our patients have good parental support and are able to help assist them in the first potentially few years of injections, of having parents give injections. But I have definitely had patients who are like, yep, I want injectable. That kind of perceived effectiveness is the injectable definitely works much better. I want that one. And then we go in and we do the session for the injection teaching, and it's oh, no, not going to happen. And so in that case, then was okay, we'll do a topical option. And so really kind of meeting the patient where they're at in terms of which route is best for them. Okay, so finally, we're going to talk about consent. So this idea of informed consent is a concept that stemmed from the ethical idea of autonomy. And autonomy is this concept that a patient has a right to make decisions, particularly as it pertains to their medical care, based on their own values and beliefs. And so when we think about informed consent, it's going to contain 2 different parts. So first is going to be your disclosure of all relevant information. So this is going to be your risk, benefit, and alternative conversation that you're having. You need to talk with your patient and equip them with all the information they need to make the decision that is best for them. The second part is going to be legal authorization. So this is the actual permission that you receive from a patient that says, yes, you can proceed with, whatever you're getting your informed consent from. And in the United States, the age to give legal authorization is 18. So adolescents cannot give legal authorization except in very rare cases of like if they're emancipated. So then we get into some of the ideas of the surrogate decision-making. And in children and adolescents, their surrogate decision maker is going to be their parent or their guardian. But a lot of these concepts will apply to older adults that maybe have lost their decision-making capacity as well. So the first idea is this decision-making based on fiduciary. And the concept of fiduciary is that you're making decisions based on the best interest of the child. And like I said, a lot of times other, even outside of healthcare uses the idea of a fiduciary. So in finances and investing, if someone is investing money for you, they are also acting as a fiduciary as kind of the best interest. This is going to differ from substituted judgment. So substituted judgment is more based on decisions that are based on the wishes and preferences of the child or whoever has their, decision making. And in pediatrics in particular, this can be kind of hard because younger patients can't necessarily express what their wishes and preferences are, right? If you have a toddler who's had recurrent ear infections and the doctor finally says, you know what, I think it's time for ear tubes. A lot of times that toddler is not going to be able to say, you know what, I think that's a really good idea. I want that option. They're just not able to express that at young ages. But we also acknowledge that as our patients age, as they come into adolescence, they start to have more agency in their healthcare, and that we do listen to their wishes and preferences more and more. And so you will find cases that if as they age and they have certain preferences, we listen to that. Now, this is a little bit complicated by the idea of parental autonomy. So parents in general are sort of thought to be the ultimate fiduciary, that parents know what is best for their child. But we are also not naive to the fact that parents do make medical decisions based on their own values and their own beliefs. And it is outlined that they have parental autonomy to do that. Now, I'm not going to get into the whole kind of nuanced discussion of when parental autonomy conflicts with fiduciary and causes harm, because that's very complicated, but just understand that there is a carve out for parental autonomy that they can make decisions that's based on their own values. So then we get to this kind of current model of informed consent. So in adolescence, you need two parts. So you need consent that's going to come from the parent or the guardian, and you need assent that's going to come from the patient. And you need both parts of these in order to proceed with treatment. When you're obtaining this informed consent, it's going to be the same as, earlier when we talked about informed consent. So for both the parent and the patient, you need to provide adequate and disclosure of all relevant medical information so they can make good decisions or what's right for them. And then in order to obtain legal authorization, it is a combination of both the consent portion and the assent portion. So how does this play into gender affirming care? So in gender affirming care for adolescents, it does require both the consent and assent. Gender affirming care is not, part of the privileged adolescent healthcare that has sort of carve outs like contraception or mental health. It requires both consent and assent. And in my experience, getting assent from the adolescent, usually not that difficult. They're usually pretty excited and want to begin therapies that you are talking about and recommending. And a lot of it then comes to the parental consent. And I really try and foster a environment in my clinic where, despite where people are at in terms of the readiness to give informed consent, that we're there and we can provide a supportive and inclusive environment. We can provide education to families, and we can provide support in however that looks, whether it's medications or not. In our clinic, we will use verbal consent for norethindrone or kind of menstrual suppression options. And this is just because this medication in particular is used for a lot of different uses outside of just gender affirming care. It can be used for dysfunctional uterine bleeding. The ACOG has recommended it for menstrual suppression even outside of gender affirming care. So we feel comfortable that obtaining both verbal consent and assent is acceptable. For all other treatments in our clinic, we do require written consent. Okay, so takeaways that I hope you were able to have from this talk. First, that thorough evaluation should be performed before considering gender affirming treatments for adolescents. Gender affirming treatment options for adolescents are similar to options used in adults, but with lower doses and more frequent monitoring. And that gender affirming treatment requires both parental consent and adolescent assent. And with that, I will take any questions. Thank you.
Going back to menstrual suppression, I used to be hormone under this. I've not had great success in adults with full menstrual suppression on that. And I would love to hear your experience in the adolescent population.
Yeah, so when we talk with adolescents, we do kind of counsel similar things in terms of the options. This might not be the best, but you know, if they're wanting something, they don't want to take a pill, and the invasiveness of an IUD is just far too much, then we tend to do the Nexplanon instead. But I would say not super, super common, but an option.
So going back to diagnosis, and in a primary care setting, I have 20 minutes for well palate checks. I see them once a year, maybe every 2 years for their sports physical.
Yeah.
Is there sort of a pre-gender dysphoria diagnosis code that would be helpful? Is there a way that you ask these questions that leaves it open? I talked about worrying about opening a can of worms that you can't, address.
Yeah.
I've had patients say they're thinking about it. What are the steps if someone just really isn't sure but is pondering it because they heard about it in their school health lecture yesterday?
Yeah.
What do I do?
Yeah. Really great question. I am certainly in a more kind of privileged position where patients coming to me typically already have kind of stated their gender diversity. I certainly get much longer appointment times than in a primary care setting. And so asking really open questions of like, what do you think about your gender, and exploring for them, like, what are they currently thinking about? Is there anything, tell me what you like about your body. Tell me what you don't like about your body. And really, if you're getting the sense that we're starting to kind of waver a little bit more into this may be more pathologic. So we're not just like, I'm, wearing these clothes or doing these things these days and they feel totally fine, but that like, I'm distressed by this. Plugging in with a therapist is really going to be the first thing. And that hopefully won't open too many cans of worms in a 20 or 30-minute visit. But kind of exploring of like where they feel it that they're at, and knowing that maybe if they're in that kind of pre-contemplative, like I'm thinking about it, that can be considered normal, and doesn't necessarily need much more follow-up than just checking in, every once in a while, like, hey, I know we talked about this last time. How you feeling now?
As a therapist, you don't have to write your letter if you say anything. That one word, even say, brought it up, you have that word in there, that has made it so I can write that letter. That happened, they said it in October. I now can put that in because you had on your chart, you write the release form. I have now been able to use that legally asterisk. They haven't said we can't. So I can now use that as my diagnosis instead of counting. So I can now send them this way. So these are the kids that are still getting their hormones that didn't have it January 28th because there's a legal documentation. So you write that, then you give them the referral to myself and the other mental health therapists. They can talk to us one way or the other, then we can decide the thing. So you write your little one word with the date of that time. Because if they take the moratorium off 2 years from now or whatever. So put your word and then you refer them to us. And then we can decide later. But you just put the word, you do your other stuff, then you put that word down and you refer forward.
So it doesn't have to be a diagnosis code. Yeah, is there a diagnosis code?
So. This is,
Your phone count according to the state. Okay. So I just mentioned it. Yeah.
yeah, that you talked about concerns about gender, or, you know, they're exploring their gender. I would say before, no, it didn't matter that you necessarily made a diagnosis.
Other questions in the audience? Otherwise, we'll go to the app. There's about 16 questions. Yeah, which if we don't get to, we can have you answer them in the online. Okay. So first question, legal consent question. So it's a little multifaceted here. If you have two parents who disagree on minor's course of treatment, for example, one parent consents and one does not, preface in Utah, we'll talk about Utah very much. How do you navigate this? Secondly, who has consenting authority when one parent is primary caretaker, but has joint custody with parent two? And thirdly, what if no legal agreement exists between separated or divorced parents when one parent is primary caretaker? You're not a lawyer.
Yeah. So not a lawyer. I would say generally speaking, though, it all comes down to who has what sort of parental medical decision-making legal guardianship. A lot of times it's going to be divided 50-50. And in those cases, we really have frank conversations about everyone being on board. So there have been instances that one parent is very supportive in the clinic with their child, the other parent is not supportive. And in that instance, it's really a matter of, do we feel like they are on board enough? And if the answer is no, then typically we can't proceed with treatment. There are instances that, you know, when both parents have legal custody and medical decision-making, and there is such a disagreement in terms of what medical care the child receives, sometimes you can go through like remediary things that basically the court decides what is the best decision. But I guess the short answer is, yeah, even if you have one parent who has custody and legal decision-making, we take that into account in terms of whether we feel like we can proceed or not.
Thank you. All right, the other question, when starting puberty blockers, what side effects and risks do you discuss for the informed consent?
Yeah, so side effects tend to be mostly injection site reaction. Sometimes, like in that schematic where you get this release of LH and FSH, patients can kind of get this like hormone rush and surge before it's suppressed. So we talk about what those symptoms look like. Side effect or kind of long-term things that we talk about and more risk-based. I tell patients and families that generally these medications are pretty safe. They're working in such a specific pathway that they rarely have a lot of interaction with other things going on with the body. The big one that we counsel on is bone density. And so we know androgens and hormones, so testosterone and estrogen, are good and important for building bone density. And a lot of our adolescents are kind of in the prime time where they're building that bone density that needs to last them. And so we talk about, what that looks like. We have not gotten to the point where we are standardizing bone scans or DEXA scans, but that is definitely something that we have talked about. And then we're with that, we're conscious of how long is someone on a puberty blocker without anything else. And so usually once you introduce your gender affirming hormone, then you're getting the hormone that is good for bones again. But that's one of the big things that we talk about.
I've had several families ask about cognitive issues with starting and running Groupon. Can you speak to that?
I usually, so I've had either like cognitive and or mood wise. And I pretty much tell families we don't really have the data when we look at other uses that have been used much longer, like precocious puberty. We don't see any obvious evidence that that's the case, but I'm honest with families that that's kind of a space that we don't really have data for.
Proactively bring that up in a consent discussion, or you address this?
I more so address if someone asks it because it's not as, I think it's not as known, especially kind of like physiology wise, as opposed to bone health.
Okay, what about the use of Depo-Provera in adolescents for menstrual suppression?
You can, again, kind of on our lower choice, much more having to do with, again, bone, the effects of bone health in adolescents. But sometimes if we're kind of going through other medications and other options, that is an option that you can use.
One more. How can those in school health settings, athletic trainers, school nurses, best support adolescents between coming out and getting them to their PCP, pediatrics care for gender affirming care? Any advice on how to navigate letting school administrators, parents know when the patient does not want them to know?
This is a hot topic. And I would say each state is legislating different on how they want to approach it. I would say taking their lead is probably the biggest thing. So if you don't have weird legislation or things happening that make it so you may have to disclose, if they are not feeling ready for that information to come out, do not disclose it. And ask them, how you can support them. I do that all the time. Asking about names, pronouns, using those, and that kind of stuff. But I would say in younger patients, and especially in a school setting, really just taking their lead as to what they are comfortable with and what they're not comfortable with. Awesome. Thanks.